Ready.
Got it. Okay. I'm Marco Grados, a professor of psychiatry at Hopkins and co-director of the TAA Center of Excellence in Baltimore, Maryland. This talk will focus on the acute care of patients with Tourette syndrome, and specifically in the last 2 years with so many challenges that have affected families and children. As an overview, we'd like to go over the diagnosis of Tourette so we have a clear idea of what we're talking about. Some features of the course of illness that are important to highlight. And of course, in the understanding of Tourette syndrome, there are many co-occurring disorders that may be the focus as well of this talk. And then we'll focus on the acute treatment in patients in crisis. Gilles de la Tourette was a neurologist in the 1880s, a pupil of Charcot, where neurology was essentially born, modern neurology, in a hospital in Paris, La Salpêtrière. And he was instructed by Charcot to write up some cases of patients he had seen with movement disorders, in particular movements which are not chorea, which were not pertaining to other kinds of disorders that were known then. And he described several patients, some of which were complex and had co-occurring disorders such as OCD. And one of the interesting patients he described was a female, older female who was royalty but had coprolalia, and this person had to stay indoors most of the time because of that. Looking at the literature, however, a disorder similar to Tourette's, if not Tourette syndrome as we understand it today, was published by James Beard in Maine. Dr. Beard had studied some males in particular who had a particular tic of jumping up and down, and it was called the jumping lumberjack of Maine. And that was before Tourette. The diagnosis itself consists of, as you know, of multiple motor tics and at least one vocal tic that exists for over a year. Now, it is a spectrum. In classrooms of 3rd and 4th graders, 20% of kids will have a tic at some point. So this is not an unusual symptom, but persistent tics is only 1% to 2%, and these are called chronic tics, whereas Tourette syndrome as such is the multiple motor plus a vocal tic over a year. Usually starting at early ages before 18, often between 5 and 7, the first tic manifests itself. And the impairment has to be understood in relation to how it affects life and how the individual interprets the tics as well. And we talked about the co-occurring disorders. The tics can be quite dramatic at times. And this is a female patient many years ago who seems to have had a strong vocal tic. And then we have the particular nature of tics, which are called stereotypic. And stereotypic means repeating itself in the same manner over and over. So this particular complex movement with some facial grimacing, opening the mouth, and then more grimacing will occur in the same sequence over and over. And this is how it's differentiated from other neurological disorders. The seat of tics is understood to be in the basal ganglia circuitry. The basal ganglia are the ancient part of the brain, which in individuals with Tourette's and OCD and possibly ADHD have a developmental maturational lag. What this means is the neurons and the circuitry of the neurons tend to mature and develop over time with a lag, and they lag behind other parts of the brain. And so they create a disinhibition phenomena. The putamen of the brain in particular, which is this aspect, is understood to be the part of the basal ganglia that controls motor movements more than other parts. And that's where it would seem to be the seat of many of the tics. Whereas the caudate nucleus over here, another view on the lateral side, is where obsessions in OCD are thought to occur mostly. So each of these nuclei have particular functions. The thalamus is the seat of sensory input, and the amygdala is the seat of anxiety and the fear, flight, or fight reaction in animal species. So this confluence of nuclei is where OCD, ADHD, and tics tend to reside. And for most cases, a maturational lag or a delay in development of the neuronal connections is what explains the tics and the OCD. Now, one can also have a stroke here, one can have injury here, and that can also produce tics or OCD, but those cases are very rare. Course of illness, as we had mentioned, starts usually between 5 and 7 years of age, starts usually in the what's called cephalic area, the head, the face, with a eye blinking being the most common one, facial grimacing, mouth movements, and then has a progression down through the body called cephalocaudal progression with the neck, the shoulders, sometimes the arms, sometimes the abdominal muscles, the gluteal muscles, leg muscles, toes, and so forth. The tics can be either simple or complex, simple being one single motor group, and complex being a sequence of tics or many motor groups. The course of illness is important to understand. Many of our patients come to us initially between 7 to 10 years of age. Even though something was observed at 5 or 6 or even earlier, around 7, 8, or 9 is when they can present more forcefully and parents start to become worried. This worry brings them to clinic where we do a lot of psychoeducation and reassurance that most of these tics, if minor, will over time dissipate. And they dissipate after adolescence. The peak of severity is around 10 and 11, but past 11 and 12, they tend to start to decrease. In a minority of patients, and percentage-wise, it's a small proportion, they persist. And that's where we have the Tourette syndrome patients in late adolescence and early adulthood. The co-occurring conditions are, as we had mentioned, ADHD and OCD, and often either start after the tics or close to the tics. So in summary, the progression of tic disorders and Tourette syndrome has an onset at a very early age, a peak around pre-adolescence and start of adolescence, a denouement or a decrease after adolescence, going to the late teen years, sometimes disappear completely or remain at a very mild level, but in a small percentage, they can be persistent. The co-occurring disorders is something to pay a lot of attention to. And one aspect of tics and tic disorders and Tourette's that to this day is not completely understood is that Tourette's disorder sits in a zone between psychiatry and neurology. So where they are motor movements, these motor movements also respond to volitional control, meaning one can will themselves to stop the tics. And one can practice stopping the tics. Of course, that's called CBIT. And we'll talk a little bit about that. In no other neurological disorder can you will yourself to stop a seizure or stop a choreic movement or change your cerebral palsy, for example. But with tics, there is some volitional control up to a point, and we can talk about what that means. There also is a phenomenon in tics where suggestibility plays a role. If you talk to a patient about the tics, more tics will come out. And there's also this new phenomena of TikTok Tourette's, which we'll talk more about, which seems to be a contagion phenomena. So there's controversy around how volitional this is and how involuntary they are. And it's somewhere in between. It's not voluntary, it's not involuntary. There's an urge to tic. Patients describe it as an itch you have to scratch. One can contain it, but only for so long, becomes very uncomfortable. You engage in the tic, the itch may go away, but it will come back, and so forth. The impairment severity are also an interesting aspect of Tourette's because you may have patients who have clear tics. Clearly, these are symptomatic, but the patient may say, you know, I'm dealing with it, I can do this. And other patients may have milder tics, but it's more distressing. So the impairment and symptom severity also have a range of interpretation depending on the patient. and of course for the parents. So what are those comorbidity or co-occurring disorders that are so salient, so important to understand for someone with Tourette's? OCD being the first one. As we saw, the brain circuitry of OCD and Tourette's is shared. And it's no surprise that many patients, half of patients with Tourette's will have what Charles Mansueto in DC has called Tourettic OCD, which is a compulsive form of OCD with a lot of touching, tapping, compulsive motor rituals, and they are done until they feel just right. And then you also have other patients with Tourette's that have both full-blown OCD with contamination fears, hand washing, and so forth. So it's a large proportion of patients that have some OCD symptoms. It's not the full disorder. In fact, ADHD is even higher. 70, 80% of patients with Tourette's have some form of ADHD or ADD, more common in females being the ADD without the hyperactivity, and in males both the combined hyperactivity and inattention. Anxiety disorders have not gotten as much attention as OCD and ADHD, but they're actually just as common. One particular form is separation anxiety, but all other forms are also possible. And we'll mention social anxiety, generalized anxiety, panic attacks, specific phobias, and so forth. Depression is not the most common, but it is a relevant feature in many patients with Tourette's. There is a mood dysregulation in a number of patients that needs to be addressed specifically. Sometimes this mood dysregulation is combined with disruptive behaviors, especially in the younger children, may have episodes of quote unquote meltdowns. In the literature, they had been called rage episodes. They're no longer called rage episodes, but they are episodes that have been described to me by patients as, I was just out of control for those 20 minutes. I just was very aggressive, very disruptive. And typically after these episodes, patients are quite remorseful and try to make up for it. And another way of describing these episodes is intermittent explosive disorder, but quite doesn't fit that criteria, and so forth. Learning problems, not uncommon either, forms of dyslexia, math disorder, reading disorder, and at times also speech and language delay. And these are in order of frequency. And to reinforce the idea that this is a disorder that has a course of illness, it's not static. This is just an example. A patient may have started with early hyperactivity. The classic ADHD is one that is described even in the womb by mothers saying, oh, that kid really moved a lot in my womb. Then the symptoms appear early in life. By 4 or 5, they're quite clear. Tics appear around 5 or 7, mostly in the face. They can start mostly with motor and then move to vocal, from simple to complex, and from head to toe. The OCD and anxiety, while they start early on, are often more salient and present a bit later, between 10 and 12. And then during adolescence, the mood problems can start. And of course, after adolescence, the motor part of ADHD decreases. Sometimes the tics also decrease, as we had mentioned, in many cases becoming milder after adolescence. What does persist is the inattentive symptoms of ADHD, while the hyperactive do decrease, and the anxiety and the OCD also tend to persist. So coming to current times and the last 2 years that we've lived, how have they affected this clinical course in children and families? The maladaptive behaviors have certainly been an issue where some families, some patients, in general, patients with chronic illness have suffered because clinical care has been diminished, hard to access during, of course, lockdowns, impossible to access sometimes. Although I will say our psychiatric services at Hopkins adapted very quickly to do telehealth. But in some cases, telehealth is not the same, especially with younger kids. So there's some limitations to that as well. Works pretty well for adults and most adolescents. The societal stress affects families, certainly increasing conflict and tension in some families. The other side of this, however, is families spend more time together and got to know each other again. It happened in our family. Um, we had led very busy lives, and when one is forced to be in the same house with your close ones, sometimes good things happen. Depression during this time has set in, however, because we feel we had this one wave, the second wave, the third wave, the fourth wave. The demoralization can set in. Demoralization is a state of hopelessness where you really don't see things getting better over time, and hope is lost, or there's less hope, which in teens who are very fragile state of their identity formation and their social relationships and just thriving with interpersonal activity, and that's suddenly cut short. We have seen certainly taken to social media, which can be toxic on its own, and then kids resort to demoralization, passive death wish, sometimes even suicidal ideation. And in someone with a predisposition to impulsivity may have impulsive attempts of self-harm. Anxiety disorders had an interesting course early in the pandemic. Many of my OCD patients actually had relief because for them it was hard to leave the house, hard to open those doors, hard to be with people who were coughing and so forth. And initially, some of them said, this is a relief. I could do this all day, just stay home. But that didn't last too long. Later, the OCD would catch up with them, and also the anxiety. Now, I don't have to remark too much on the learning processes in children during the pandemic and the school.
Dr. Grados, you are on mute.
Do you know how long I was on mute? Because
I would go back about 30 seconds. We're hearing a scraping in the background, so we went and did a mass mute and you got muted by mistake, so our apologies. If everybody could please keep themselves on mute, that would be greatly appreciated. You maybe go back 10 seconds.
All right. So I did mention at the end, anxiety disorders in some of our patients got better initially. These patients were very relieved to not have to go out again, contamination fears and so forth. But the OCD would later catch up with them. And then all the learning challenges during the pandemic are well known. And all this accumulates in families and kids. And we're still going through this. So what happened? And this is a quote from John Walkup that I won't claim credit. Children with TS are, quote, more difficult to parent. Yes, in some ways, everybody's more difficult to parent these days. Why? Well, we have those co-occurring conditions which affect function, affect family relationships, create tension, and we can't treat them as well as we used to with only Zoom sessions, right? Although they can be very effective, and many of our patients like the Zoom sessions because they don't have to leave their homes. At times, they can be less effective. The paradigm that you work with in the conceptualization of tics is so important for families. On the one hand, it's, quote, not their fault. On the other hand, as we had commented before, this should not lead to enabling, to lax rule setting, and also something my psychology colleagues impress on me over and over again is that a child unwittingly may have tics under conditions that are uncomfortable or unwanted for them as a form of escape. Escape meaning tasks, structure, limit setting, homework, and so forth. So that has to be modeled and shaped through CBIT. One has to be careful with that. I put here a note about TikTok ticks. I'll talk more about that later. And so John would say, quote, he can't control himself is a common misconception. I have heard over time, and it is a truism in our field, that children with special needs need more parenting, more structure, rather than less. What's the developmental impact? Well, again, teenage years are a very sensitive time, and unable to have those relationships, those very, very important contacts socially, is going to impact identity formation and what you think of who you are. And doing it only in social media can be a plus, but at many times it's not the way to do it. So we have to be attentive to the goals, aspirations of adolescents, reinforcing those and keeping a closer eye on things than you would have otherwise. And John would also talk a lot about the Tourette syndrome becoming part of one's identity. That is a mixed, if you will, a mixed experience as well. That can be helpful. One can really own it and overcome it, or one can ignore it. And of course, going in both directions, either way, may not be the best way to do that. And this can, what I'm saying at this point can generate questions. I welcome your questions. So treatment is effective, as hopefully you've experienced. CBIT on the therapy side, John Piacentini at UCLA and collaborators developed this treatment almost a decade ago. When it first came to our clinics, Harvey Singer, the neurologist I work with, and myself were, interesting approach, worth a try. And it's been quite successful in many patients. And the data show it, so it's evidence-based. The components are important to recognize. It's not a single approach. It's a combination of different approaches that have worked over time in different therapies, but have been adapted to the use with patients with tics and Tourette's. Initially, parent management training. Important to have the parent be in control of certain behavioral aspects of the child's life, and that can take some work with a therapist. And that's called parent management training. It sets the ground for what comes next. If there's a lot of anxiety, one can implement CBT for anxiety. The first step specifically to tics is awareness training, making the child, the adult, aware of the urge to tic. Once you have that awareness, it anticipates doing the tic, executing the tic, and what you practice is what might be called habit reversal therapy with competing responses. So if I have a tic that's making my arm move like this, I might come up with a competing response of folding my arm and not doing the tic. It may be uncomfortable at the beginning, it's less uncomfortable later. And as I practice that and I don't execute the tic, a habituation process seems to set in, either that or another reinforcement mechanism, whereby the urge to tic tends to die down. But that's where therapy and exercises with competing responses can be very helpful. You might wonder how this therapy even initiated. It was initiated by patients themselves. Adults with tics had practiced this on their own and had told their providers, this is what I do, and it seems to work. And then it was protocolized and formalized. For anxiety, OCD, but also for tics, this can be also considered an exposure to urges and exposure to anxiety. And then making the patient more functional at the end is the key. Does the tic have a function? And I had mentioned children may start ticking when they start homework. Not necessarily voluntary. This is not malingering. It is a form of expressing anxiety, maybe stress, maybe discomfort with the activity. And if we say, okay, you don't have to do homework tonight, the lesson that the body learns, not necessarily the kid consciously, but the body learns, if I do a lot of tics, I can start getting out of things. And this is shaping the behavior and shaping the tics, which is what CBIT is meant to do. In the other
Dr.
direction, of
Grados?
course. Yes.
If I may, we have a question regarding tick
Yes,
suppression. It's a question from Jill Arnold, and she's asking, how long can a tick be suppressed for? Is there a time limit? How many minutes?
a good question. So when the urge is strong, um, we don't aspire to suppress the tick completely at the beginning. It is like an exercise that takes practice. A hierarchy of ticks is also developed with the therapist. So we go for the simple, less intense ticks initially and work with the patient for them to practice suppressing a tick that's not so strong. And in those cases, it tends to go well and you can suppress them for a long time. So if you start with a bigger tick, with the one that has the highest urge, you may not be able to do it for a long time. It could be 30 seconds, a minute, or even less than that. So it is a process, and it is a process of training oneself to be able to practice that suppression with the lesser ticks and moving on to the higher ticks. On the other hand, the art of the process is that some lesser ticks don't have a lot of urge. They just tend to be more spontaneous. So you have to start with those ticks where you can have the tick awareness, or the awareness training piece can work, so you know the tick is coming. And CBIT tends to work the best with the bigger ticks. So a coprolalia tick, for example, when one is cursing in inappropriate settings, you can put your tongue in the roof of your mouth every time you have the urge to curse. Now, it's not easy, and it'll prevent the coprolalia, but sometimes you can't maintain that. But that's another example of a competing response that would suppress the tick and suppress it effectively. Uh, but that's where the art of the therapist comes in. And I'm not a CBIT therapist. My colleague Joe McGuire is the expert, and I have learned from him.
Dr. Grados, we do have another question. The
Sure.
question, and again from Jill Arnold, is, are there behavioral strategies for coprolalia?
So the one I mentioned is the
I think he
competing
just did it with
response.
the roof of his mouth. Yeah, with the tongue to the roof of your mouth. I think you touched on that. I wasn't sure if there are any others.
I think I heard that, but I'm not sure I understood.
She's asking if there are any other strategies they can use besides the tongue to the roof of the mouth.
Right, right. Anything that's incompatible with a tick. And again, Dr. McGuire would be able to ask. He is very creative with these things. If you have a tick that some people have breathing ticks, every time you have an urge to do a coprolalia tick, you might blow out with your mouth. Can you say something as you're blowing out with your mouth? Probably not. So you look for things that are incompatible with performing the tick. Just give you the general idea, working with the individual therapist is very important. So that's CBIT, just an overview. That you know it's out there, it's very effective. And this is what we do in our pharmacology clinic, the pharmacology. So for mild to moderate ticks, we have options of alpha agonists, they're called. What they tend to do is decrease the sympathetic system in the body. We have two systems, the sympathetic and the parasympathetic. The sympathetic system, it's a nervous endings all across our body called sympathetic nerve endings. They occur and they are initiated during moments of stress, during moments of action, and it puts you on the alert. So your heart rate goes up. You may dilate your pupils, you may do things like that. That's the sympathetic system. The parasympathetic is the opposite. So these medications tend to decrease the sympathetic system. So they have a relaxing effect. They're also blood pressure medications. And it's not entirely clear how they decrease the tics, but they can be quite effective in mild to moderate severity tics. Clonidine is short-acting, more sedating, and has to be used more than once a day. There's a version that can be used twice a day. It's called Cape. Guanfacine, also called Tenex, is longer acting, less sedating, but maybe somewhat less effective than clonidine. So working with your physician to do the risk benefit and the side effect efficacy equation is important. And we have long-acting forms of guanfacine as well called Tenex, or called Intunif. Guanfacine is in Tenex, and Intunif is the long-acting form of guanfacine. The mild to moderate ticks can be helpful, these alpha agonists. For more severe ticks, and this is a real threshold that one crosses only at a certain point in Tourette's course of illness, which is saying, do we need a neuroleptic? When I teach residents to use psychotropics, I leave the neuroleptics as the fourth class, something to be used only if needed. Now, if the tics are moderate to severe and impairing, certainly an option. We have the older neuroleptics, Pimazide, very effective back in the day. Prolixin, I apologize for the dog. There's going to be a little bit dog in the background for a few minutes. Prolixin, quite effective. I use it second, third line these days for tics that are difficult to treat, including carpolalia. And Haldol not used very much, or OREP. But they had a property of inhibiting what's called the D2 receptor in dopamine type 2 receptor. Dopamine has at least 5 type of receptors, and D2 is the key one for these disorders. And if you inhibit the D2 receptor of dopamine, you tend to decrease the tics. And that's what these old neuroleptics tended to do. OREP, quite effectively, not used much anymore, and Prolixin, I still use. Haldol, never quite used at all.
Dr.
But these days we
Grados,
have,
you have 2 questions.
Thank
yes,
you,
please.
I'm
Devin.
sorry, Grotto, excuse me. We have a couple here. One from, forgive me if I pronounce this wrong. Oops, sorry, someone just scrolled down on me. Milagros was saying that, I'm assuming this is their daughter, she is starting to be self-conscious about it. Will it be a good idea to show her she can use not the only one? What can you elaborate on that, please, Milagros?
Yes, it's me. So my daughter started the tics when she was 5. Now she's 7. At the beginning, she was not like self-conscious about it, but now she's starting to say, why me? I am not normal, something, see things like this. So I was asking if it will be if it will be a good idea to show her that she's not the only one to have tics, and there is other people that also have tics, or how can I approach these? Thank you very much for this conference.
Yes, thank you for the question. A 7-year-old girl certainly will be quite sensitive to having tics at times, even if they're not severe tics, even if they're mild tics. That's the bane of having small dogs. They do this kind of thing. I apologize. So different than boys. So if you have a little boy, they can have quite significant tics at times, and the parents are so concerned, and the boy says, my friends think it's interesting. But different with girls. So that's one thing in this particular case. The other one might be, certainly need some, I would suggest some therapy approaches, not just for CBIT, if that's possible, but also to help her understand what kind of disorder it is, what's the course, it's going to go away, and prevent falling into depression or anxiety. Sometimes we have kids who say, I have social anxiety because I don't want to go out because I have tics. So is that social anxiety, or is that just somebody who doesn't want to be seen with tics and becomes socially isolated and socially anxious? So it's important to address it early from the therapy side to prevent that kind of reaction. And in terms of, she's not the only one, she certainly is not the only one. 1% of children have a tic that lasts more than a year. And so I believe the TA would have also some resources for children to understand that they are not alone. It's important for them to understand that. There was a question on guanfacine and executive function in the chat.
Yes, we have 2 more questions. One says, can you speak more as to how guanfacine may have more effect on executive function? And what do you actually mean by this?
Right. So I still left it on the slide, although I'm not sure I'm a strong believer in it. When guanfacine first came out, it came out of the Arnstern group in Yale. It was a very big thing because it was better than clonidine, less sedating, longer acting, and the animal experiments had shown that these mice could perform certain things that are considered executive. So the mouse brain is not the same as the human brain by any stretch, but that was the way guanfacine came out at first. That's still not quite definitively proven in any particular way. What is important is that guanfacine and clonidine, which I have not mentioned so far, help with ADHD as well. And they help the impulsive nature of ADHD. So ADHD, and we'll say a word more about ADHD, has the impulsivity, hyperactivity, as well as the inattention. And they're 2 different domains, and they're quite separate, actually. And clonidine and guanfacine will help the hyperactivity, impulsivity. So to that extent, it can help in executing actions or what's called executive function. But I'm not sure that it has a specific effect on executive function, even separate from clonidine. It does help hyperactivity, impulsivity, though. So hopefully that clarifies some of that. And there was another question.
Yes, one more question from Deborah Slater. Can medications increase tics? Have you ever seen tics increase with SSRIs?
Well, somebody just told me today there was a child that's put on Celexa and the tics increased quite a bit. It is not common, but it's not completely uncommon either. I would say 5% of the time somebody with some tics may increase their tics. It does happen. It's unclear why. Zoloft is one particular SSRI that has been shown in the POTS trial of OCD to maybe worsen tics. And there's a reason, because SSRIs, and I won't go too far into this, but SSRIs are serotonin reuptake inhibitors. They increase serotonin in your brain, and that increases neuroplasticity. With Zoloft, it also increases dopamine. And we know that one particular theory of tics is that dopamine receptors are oversensitive, hypersensitive dopamine receptors. Harvey Singer put that out there many years ago. So even the normal dopamine that we have in our brain may be causing tics because those receptors in the basal ganglia, those structures I showed you, are hypersensitive, and that's developmental. So with a medication like Zoloft, which has a dopamine effect, this could happen. And again, some data shows that specifically with Zoloft. Why with others? Unclear, although serotonin modulates dopamine. So there is a possibility that it's changing dopamine levels as well when you use an SSRI. But again, not common, not the most common occurrence with an SSRI. So we went through the old neuroleptics, and old is relative, but fluphenazine is, again, one I still use when I hit a roadblock with the more popular ones these days, which are the atypicals. Atypicals are quite useful, quite helpful in severe tics, in people who are quite impaired with tics. The top of the line is Risperdal, Risperidone, aripiprazole, Abilify, and those are the 2 that, for me, have had the best results. Dr. Singer in his neurology clinic might go to Zyprexa, Geodon, those 2 in particular. Seroquel, possibly not as good for tics, but very good for anxiety. And Clozaril, although it's listed, I don't know somebody who's used Clozaril. Clozaril is a very difficult drug to manage. Side effects are the issue here. So all of these all of these can cause weight gain, and sometimes significant weight gain, depends on the patient. All of these can cause metabolic syndrome, which goes beyond weight gain to a pre-diabetes state as a separate problem. And so monitoring is necessary. When I have patients start on these medications, I tell them, one, you're going to watch intake. You're going to see that you're going to have an increased appetite in what you eat. Tell the parent what this child gets as a second serving or so forth has to be something different. A lot of broccoli, asparagus, or lettuce as a second serving, and they'll eat it because they're hungry. But have the regular meal and then be ready for a second serving of something more healthy. Strategies like those important as you start the medication. Before you know it, there might be weight gain and that downside. They also can be sedating, and that's variable, but it can be sedating. So kids may go through the day just a little more tired throughout the day. They can also cause, on their own, separate from the tic movements, rigidity, which is called dystonias. And these are not common, and they're solvable by stopping the medication or using cogentin or medication that counteracts the rigidity, but that can happen as well. So you have to go into this group of medications with good advice and consulting closely with your physician and asking about all the necessary measures you have to take because of the side effects. Very highly needed as well is the blood monitoring when you take these medications. So regular 3 to 6 months interval taking of diabetes markers such as hemoglobin A1C, glucose, lipid profiles, and so forth. But they can be very useful and for many patients quite helpful for severe tics.
We do have another question, Dr. Grados. This one is from
Yes.
Phil Cuppernell, and it says, it seems like there are lots of medication options. Is there a way a doctor may choose one specific drug? Our last doctor seemed to just pull a drug out of a hat and see what happened, then another one if it didn't show benefits.
Yes, that's what it feels like sometimes. So mild to moderate tics, this is what works. If it works, this is what will work. Clonidine or guanfacine. Severe tics, old school, I still like fluphenazine. And then this is what you'll be offered if the tics are relatively significant. And of these, the first two are the ones that, in our experience, have had the most benefit. Beyond that, it may be hit or miss. And yes, a patient can get better with Geodon. I've seen that. With Zyprexa, I've seen that. But they are more the exception. And Risprel and Abilify are first line. So bottom line is there are many options. There's a new neuroleptic every 6 months on the market sometimes. That's how it feels. So probably, as we say with OCD and other disorders like these, an expert consult at least once during your treatment is a good idea. If psychiatrists who are treating or neurologists who are treating this have some experience, but not a lot of experience with Tourette's, asking for a second consult or a one-time consult with an expert center, a center of excellence, is not a bad idea. And so this is from Harvey. It's Harvey Singer. This is this paradigm for tics. You do psychoeducation. Do you need treatment or not? When they come young to the clinic, 7, 8, 5, 6, and the tic is relatively not a large tic, few tics, they may just go away. And so the reassurance is one of the things we can do in close monitoring at those early ages. And then because ADHD is very common, consider some behavioral interventions. So it has to be a comprehensive evaluation and not just aiming for the tic, but all those co-occurring disorders should be examined. The first tier, clonidine, guanfacine, and I list others here just because they've been used, but there's less evidence for those. Topiramate or Topamax may be an exception. It's used a little more, but again, those are not bolded and not commonly used. In the second tier, I like fluphenazine for the complex tics, with an older medication, and then risperidone, or Abilify aripiprazole. Can one do deep brain stimulation? It's a very interesting area of investigation. The brain imaging studies show that the urge is coming from a particular part of the brain. It's called the supplementary motor area. The supplementary motor area, which is a cortical area next to the motor area, seems to be a place in the brain where movement is planned. So, for example, you're going to swing a golf club, your supplementary motor area is already programming that movement. And then the motor area executes the movement. So when one has urges, and this has been imaged by Brad Peterson, who's now at USC, the supplementary motor area tends to light up. So the urge may correlate, and this is not absolute, more studies are needed. But the supplementary motor area is connected to the insula of the brain. And in patients with Tourette's, apparently it's hyperconnected. So what does they mean? Well, the insula of the brain is and I have images in other slides, I don't have it here, is a small part of the brain that is between the frontal and the temporal lobes. So the two big lobes, one opens that up and there's a little mushroom-like structure in the middle. And that's called the insula, which means island in Latin. So the island of Ryle. And this insula is very, very interesting part of the brain because it almost is like a small brain of its own. It controls, again, things like autonomic nervous system, blood pressure. It also controls sensory input. And for example, the emotion of disgust, which is a strong emotion, is one of the 6 emotions we have, resides in the insula of the brain. But the insula of the brain also has what's called the interoception. And interoception is how you feel your body. So right now, I'm sitting in a chair, my feet are on the floor. I stubbed my toe this afternoon. I have to examine it later. And I'm feeling that too. So that's the insula of my brain is giving me a body map. And so the fact that the insula of the brain is hyperconnected to the supplementary motor area makes logical sense, almost too much sense, that where the urges are is connected to where you feel your body. And as we know, patients with Tourette's are very sensitive about sensory input. Sometimes they feel things excessively. They're very sensitive sometimes to clothes, to tactile sensitivity, to loud noises. This has been called sensory integration. And so there's something to that. So the long story short, deep brain stimulation or transcranial magnetic stimulation is a magnet that you put on the cranium. And you put that magnet there. Now they look more like those old hair dryers that you used to be in. And you sit there and the magnet is affecting your brain waves for 20 minutes, once a day for 28 days. You go in weekdays for a 20-minute session, read a magazine, and you get the magnetic field there. What it's doing is interrupting that connection. And it's interrupting it so the brain can rewire itself. And so that's a very interesting area. We're trying to do some research with that, but not quite there yet. There's newer drugs that are being researched. One is tetrabenazine has been known, but other forms of benazine, like deuterabenazine, may come on the market. These are depleters of neurotransmitters. So the movements that anybody has relies on transmitters, dopamine in this case. And so what tetrabenazine and the other benazines do is they deplete the transmitters so the transmitters are not touching the synapse anymore, and that tends to decrease movement. Unfortunately, it has a lot of side effects as well, because as you imagine, depleting the neurotransmitters can cause depression and cause other things. So you have to watch that. Botox has been used for specific muscle group. We had a patient who had a very, very severe vocal tic, and he would yell, this big yell. You could hear him a long time a long distance away. And it was unrelenting. The patient also had autism. And it got to the point where nothing worked because of the autism. There wasn't a lot one can do in terms of therapy. But he would come in every 6 months and get some Botox to his vocal cords because the patient was nonverbal. So the decision was made to do that, and it helped a lot. There's some newer or different neuroleptics, sulpiride being one of them, but they're not available in the United States. So the bottom line is there is standard treatment, and there are other options, second or third line, where it's going to feel like it's more of a hit or miss. But these that are more standard tend to have good results, thankfully.
Dr. Grados, we do have two
Yes.
questions on the previous slide. One of,
Yes.
actually, you have three. One from Kara Edwards. How can baclofen, if I pronounce that correctly, how can that help with tics?
Yes, so baclofen is used for cerebral palsy. And in cerebral palsy, you have muscle stiffness and what we call hypertonicity. So the limbs tend to be tightened. And baclofen can relax those. It has an effect, a GABA-like effect. As you know, Valium, which is a benzodiazepine, which uses GABA as a transmitter, can also do something similar. So baclofen may be able to relax certain muscle groups to the point where the tics are lessened. I have not used it, but it's listed here as one of those alternatives. One use maybe, and I would not say it's commonly used at all. Was that the only question? Oh, do
No, we got
anticonvulsants
two more.
benefit?
Actually, sorry, three more.
Okay.
This one is from Amber Turner. She says, my mom was recently diagnosed with Parkinson's. Is there a genetic link, and can some of these medications be used to treat both TS and Parkinson's?
And I'm assuming your relative has Tourette's and Parkinson's? Oh,
My daughter
that's-
has Tourette's. My mom has had Tourette's diagnosis for 3 years, and my mom was just recently diagnosed with Parkinson's, and I know they both have to do with dopamine levels.
They do. So Tourette's is the hypersensitivity of the receptors with normal dopamine levels. It's a theory. It has a lot of backing to it. Parkinson's is the lack of dopamine through the death of cells in the so-called substantia nigra of the brain. And so there's less transmission to the point where muscles are not moving very much, and it causes a rigidity that's very particular to Parkinson's. So they're not connected either genetically, and the treatments are very different. So in Parkinson's, you give dopamine, right? L-Dopa, Simitrol, or those medications that give dopamine. In Tourette's, you try to block the dopamine.
Okay.
It's a bit reversed, but they're both movement disorders, classic movement disorders.
Thank you.
Was there another question on anticonvulsants?
Yes, so actually there's one right before. This one's from Jessica Salinas. I take quadapine and gosh, these names, clonazepam, but I still have significantly strong tics. Does this mean that these meds are just not working, or are these?
Well,
yeah, and then it says I have bipolar and extreme anxiety that I take for those.
right. Although clonazepam is listed here, it's another one of those non-specific medication for tics. It is a benzodiazepine, which, like Valium, Ativan, Xanax, can cause lessened anxiety, and that's what it's used for. If anxiety drives the tics, it could be useful, but it doesn't have a specific effect on tics. And it's used widely for decreasing anxiety in many conditions. And then, was it anticonvulsants? Was the question?
Yes, the next question was from Caroline Miller. Do anticonvulsants provide any benefit in managing Tourettic OCD with co-occurring mood dysregulation?
Yes, so there's a connection between bipolar disorder and seizures. If you have a patient with seizures or a patient with bipolar, the relatives will have some seizures, and the relatives, okay, explain it this way. If you meet a patient with bipolar disorder, relatives might have seizures in the family tree. if you meet a patient with seizures, relatives might have bipolar disorder. So anticonvulsants have been used for bipolar disorder as well as for seizures, of course. Medications like Depakote, lamotrigine, Lamictal, in this case, topiramate, Topamax, have been used for bipolar disorder. So if you have mood dysregulation that's not bipolar disorder, and bipolar disorder, by the way, is uncommon. One of the things we struggle with is many patients being diagnosed with bipolar where it's not quite bipolar. Bipolar is defined as a presence of a manic episode, and it's a very high threshold to have a manic episode. Aside from that, anticonvulsants can be helpful in bipolar disorder, but also in mood dysregulation. So some patients with depression in a lot of mood swings can take lamotrigine. It's actually common practice these days. And there's some data, it's not the strongest, but there's data that it helps with mood dysregulation. And again, if mood dysregulation is causing tics or tics are causing mood dysregulation, then it can be helpful in that sense. It's not, as far as I know, specific to tics. It's to treat the mood component that may accompany the Tourette syndrome. Good questions. And here we have the depiction of the iceberg where the tics are the tip of the iceberg, but we have the co-occurring, coexisting conditions underneath. And we have a question here, which I'll address in a minute. So what's important about this is that sometimes the tics catch the attention of the parents, but as you do the interview and the intake, you realize the child has possibly ADHD, some OCD features, some sensory sensitivity, and anxiety disorders. And that is affecting the child's life just as much and often more than the tics themselves. So that is why when we meet a patient in a family that kid has Tourette syndrome, we want to do a comprehensive evaluation and not just focus on the tics as tics. So that's the paradigm here that's important to consider. There was a question about vitamin B6 and magnesium, I believe. These are supplements that help neural transmission. So if they're helping the right neural transmission, it's possible that they could improve tics, but I don't know any study that's proven that conclusively, but it's an interesting observation worth pursuing. So let's go into some of these.
Oh, I'm sorry.
Yes? Oh, go ahead.
I was gonna say there was one more question from Shannon Gromes. It says our son's ADHD has been a huge challenge. Concerta and Stirata both made things worse. Recently, we took a risk on Adderall and anxiety and tics have improved. Have you seen this before? And if so, does it last?
Yes. I'll talk about ADHD in a minute, but Adderall is a good ADHD medication, and decreasing the ADHD itself may bring down a trigger for the tics. And there's still some connections that are not well understood between these disorders. Making one better can make the other one better. And I see that all the time. Sometimes the OCD, I just had a patient yesterday. It was yesterday. This patient has Tourette's, OCD, ADHD, and autism. And those 4 disorders, by the way, are very special. Those are the 4 disorders that arise before puberty, full-blown, and it constitute a whole world of themselves. And I'm not too surprised the kid has the 4 because they share genetic risk. And so in this kid, we had tried Ritalin, helps with the ADHD, had tried some alpha agonists for the tics, but it's not until we got a really good control of the OCD that now it was well controlled now after a long time. And he says, the tics are almost gone. My mood is so much better. And yes, the OCD is better. So sometimes focusing on one of these disorders and getting that to a really good place can affect the other disorders. Not as common to see the ADHD being the one that improving the tics, but I could see that happening. And whether it's sustained, I would think so. I would think so, as long as the ADHD receives good treatment. And so to go into some of the co-occurring conditions, OCD and anxiety, very treatable, high effect sizes for psychotherapy, for SSRIs, worth treating, sometimes aggressively, like in the case I just described. Depression, not the most common co-occurring condition in tics, but certainly can happen. In good treatment, again, for depression, CBT, the classic TAD study funded by NIH has shown that CBT is effective for depression, and we have an array of antidepressants as well that can be used. And here's the question about mood stabilizers being helpful. It's for mood dysregulation, what comes with depression, and sometimes children with Tourette's who are complex will benefit from those as well. ADHD, so 70 to 80% of patients with Tourette's will have some form of ADHD. The inattention responds to lower dose of stimulants, the hyperactivity impulsivity to higher doses. You want to be aware of that. And the higher dose, the alpha agonist, clonidine guanfacine, can also help the hyperactivity impulsivity as they help the tics. So you get 2 for 1 with the alpha agonist sometimes. There was a question about N-acetylcysteine. N-acetylcysteine, or NAC, is an antioxidant. It decreases oxidative stress. There are 2 things that are still need to be understood, and we're involved peripherally, but more than peripherally, in these 2 things. They are oxidative stress and inflammatory markers. And both of those are possibly affecting Tourette's, OCD. You've heard of PANDAS or PANS. And there's inflammation there, but it's not neuroinflammation. The neurons are relatively intact. It's inflammatory processes that are more subtle. And N-acetylcysteine decreases both. Decreases the load of oxidative stress, which is when cells become overactive and age early and then degrade, maybe die off in neurons. So N-acetylcysteine decreases the oxidative stress, decreases the inflammation. Used as an adjunct, however, would probably not be a single drug, but you can add it on to a regimen. So this was ADHD. And now finally, say a word about crisis management. So crisis management currently is a challenge. Our mental health resources were strained before the pandemic. We were calling out systems to say this is a chronic crisis. During the pandemic, we have had telehealth, and that's been relatively okay. What's not available is acute care services in many of the step-down options. So you have the outpatient and you have the acute care and nothing in between. Many of those services closed, reduced in-person visits, and so it's a crisis within a crisis. Everybody goes to the ED, emergency department these days, seeking treatment. It's unfortunate. That's all sometimes you can do. But where we resolve the crisis, where do we link you to? What outpatient service? So it's a challenge. It's a challenge. We have started to have initiatives to create programs such as bridge programs. So you come to our ED, you get an evaluation, and we can't get you an outpatient therapist for, say, 4 weeks, or a psychiatrist for 6 weeks. We will see you in between and make that bridge happen. Our day programs tended to have patients for 14 days, and we had incredible demand. So we said, let's do it for 7 days instead of 14 days. It's working just fine. And we can see the double number of patients. So being creative in these difficult times is paying off to some extent. Our inpatient unit is not taking direct admissions for a few reasons. One, because of COVID, especially when we're at a high level of COVID. Also because our wait lists in the ED are so long to begin with. The other day we had 16, 20 kids waiting for a bed. We only had 1 bed open. COVID has also decreased interpersonal contact even inside the unit. So we tended to do a lot of one-on-one conversations and therapy sessions with patients. There's some limit to that because of COVID, and doing it with masks is not the same. We had a biomode unit inside our inpatient unit. Now we're talking inpatient psychiatry. A biomode unit is one of those units where you go in with negative air pressure and you have to put the sort of the spacesuit on and so forth. We had psychiatric patients being treated that way during the height of the pandemic in the spring of 2020. We are testing kids all the time, and when they turn positive, they then have to be in isolation. They can't leave the room. So this has been a struggle in the last 2 years. We have seen an increase upon increase of emergency room visits, especially with suicide attempts in female adolescents. The national numbers are an increase of 40–50% of suicide attempts. And unfortunately, completed suicide, especially in female adolescents. Those numbers came out a month ago, less so in males. The other phenomenon in the pandemic has been this TikTok Tourette's phenomenon, where patients with Tourette's have been on TikTok, in some respects, normalizing the illness, right? So the kids would see it, oh yeah, this Tourette's. I know what it is now because these kids are showing it to me. In a group of adolescent females, it has caused some contagion. So we've seen kids come to our ED with very violent tics that occurred all of a sudden when they didn't have tics for years, or they never had tics, is what they say. And so this is a new phenomena. It's being written about. Joe McGuire has written on it. It's not volitional. These kids are not making it up. It's a contagion kind of phenomena, and we're still trying to understand it. It overlaps some with what we call conversion disorder or functional neurological disorder, which can be treated in a different way. You don't need to load these kids with medication. So that's also out there. Just wanted to say a word about suicide. If patient with Tourette's becomes demoralized, and in this time, difficult times for families, we want to be very attentive to this possibility of suicidal ideation and hopefully not suicide attempts. But it is happening, and for whatever reason, female adolescents are the highest risk. These are the definitions. Of course, suicide is a complete death, completed death with intent to die. The attempt is a non-completed suicide. It's non-fatal, but what had intent to die. Ideation is just having the ideas. And then there's the cutting phenomena, right? That's non-suicidal. One of the lessons is that, see, this is a very important public health problem right now. It affects everyone, including patients with Tourette's. Second cause of death between 10 years and 34 years of age. Second cause of death, right? It's very important to note that resources, mental health services are just not available for many of these patients. National initiatives are out there. Zero suicide risk models, screening of patients in pediatric clinics, screening in hospitals, trying to get these things detected early is important. It is happening. And we have these protocols where anybody who has a suicidal ideation gets put in a level of risk, and services and treatment offered. Just want to point attention to the cutting sometimes that we see in patients, youth under distress. Cutting is a coping skill. So children under distress tend to do this because they feel relief. Now, it's a very bad one. It'll leave marks. It's not meant to die. So I have here, self-cutting does not equal suicide attempt. It's very important. We need to teach them better coping skills, different coping skills, and work with these youth.
Dr.
And
Grados?
some people, yes.
If I may, I just want to interject. It is, well, it's 1:15 in the morning for me, but I just wanted to make you aware that we have 15 minutes left. Also, my phone is blowing up with people that are on this webinar saying how helpful this is, and the information is just life-changing for them. So I want to say thank you. I want to make sure we respect your time. We have 15 minutes left. We can go over if you would like to go over. Whatever you would like to do, it is completely up to you.
These are my last 4 slides, and then we
Okay.
can just have a few
Wonderful.
questions. Wanted to point out
Yes,
for
we do have a few
adolescents.
questions.
Oh, can I
I'm sorry, Dr.
finish
Grados,
maybe,
we
and
do
then
have a
we'll
few
take all the
questions.
questions? Is it
Okay,
possible to
understood.
finish the slides? Then we'll just take all the questions. So the cutting, right, phenomenon, it's non-suicidal, but it can be very distressing for families and for the children themselves. Happens mostly on weekends. Okay, not mostly, it's higher on weekends, but it also happens in evenings. So we recommend patients under depression, isolated, COVID-related, can't see their friends, feel distressed, more structure and more monitoring on the evening hours. Sometimes you say, just do what you want, and so they'll go to social media. And this is what this shows. This is 100,000 kids in Germany that were their Twitter accounts or whatnot were mined. And what they found was self-injury was mentioned and happened after 6 p.m. and reached the height at 9 p.m. So just a note there. Weekends, downtimes, unstructured times, evening hours, more monitoring, more structure. And to note at the end that this has also good treatment models. One is DBT, dialectical behavior therapy. You may have heard about it. It's very effective. It's been now in adults taken down to adolescent ages, and it results in less suicide, less emergency room visits, less inpatient unit stays. And it is a form of CBT, cognitive behavior therapy. It's called DBT. And I won't go into the modules, but if you hear about DBT, it's very effective for kids who are under distress with self-harm, self-injury, or suicidal ideation. So in summary, hopefully we've done a tour of Tourette syndrome, early onset, variable expression, co-occurring conditions need to be addressed. Sometimes they are the crux of the problem for these children. And then crisis management can be precipitated by these different things, right? Episodes of discontrol, mood disorders, complicated depression, illness during the pandemic, which is chronic and unrelenting. And this is our hospital. My office is in one of the high floors of that building. It's a new building. We're thankful for that. The Children's Center at Johns Hopkins. And we're one of the centers of excellence. And please bring on your questions.
All right, so we have a few. This is from Kara Edwards. She has a two-part question. What kind of pharmacological therapy is recommended for a child who has been unsuccessful with CBIT due to lack of effort, but gets upset about his tics and how others respond to him?
And was the first one phonological? Is that what I heard?
Pharmacological, yes.
Or pharmacological?
Pharmacological, sorry, non-pharmacological.
Okay, non-pharmacological. Right, so it seems to me we have here a child who's not motivated. We have protocolized many things in psychiatry these days, and one is called motivational interviewing. There's some therapists who are pretty good at this, which is getting the child to a place where they might see the need for the therapy, whereas before they did not see it. It is a therapist who can work with a kid, and it doesn't have to be a terribly skilled therapist. Say, well, what are the pros and cons? What if you do it? What if you don't do it? How would you how would your life to be? And how is this incompatible with how you would like your life to be? The child may also be depressed. We may need to treat a depression here. And so there's different possibilities, and a good, thorough evaluation would be important. Next question.
They wanted to know in her second part, where can they find this kind of therapy that you were recommending?
So the CBIT is maybe the question, and I'm pretty sure the TA has resources to find therapists by region, by geography. I don't know if it's worldwide, but pretty sure in the United States.
Now this one is from Maria Delia, and this might have been something you were talking about, because it says specifically, what about OCD, intrusive thoughts of suicide or to cut? I'm not entirely sure.
Yes, so it's important to differentiate. We've had patients with depression and OCD, and sometimes they're suicidal, truly suicidal, and sometimes it's intrusive thoughts of self-harm. These patients have both, and you have to treat both. It's almost impossible sometimes to say, well, this one is OCD and this one's the depression. They just tend to start to come together. And in those cases, I've seen most of the time the depression take over. So I would lean towards treating depression aggressively, unless it's really just OCD. And some people with OCD will have intrusive thoughts of harm, self-harm, but they say, I don't want to do this. Why am I having these thoughts? They don't make any sense. In that case, it's just OCD, and then you treat OCD.
All right, the next question is
Next.
from Amber Turner. When my child had their attempt a year ago and we were in the ER, I had no clue what to expect. Can you explain how that process goes for people who may not have experienced it yet? Like what goes on in the ER psych rooms while you are there from when you get there to when you leave?
Yes, thank you for that question. It can be a journey. You come into the ER, you'll get an evaluation. Often it's a social worker. Most ERs don't have psychiatrists. Some do. We offer child psychiatry. And so we'll get a evaluation, and the evaluation can go, well, you need inpatient treatment, so you have to wait for a bed, or we don't think you need inpatient treatment, and here's what the resources, and hopefully it'll give you more than just a phone number. So it can be unsatisfying for sure. Ask good questions, keep asking them if you're not satisfied. We're here to help, and the resources are scarce. If you need an inpatient stay and you hesitate because maybe the hospital is not the hospital you want to go to, you can try to ask for a different hospital. Most ERs would honor that. We honor one request at least for which hospital they would like to go to. But it is a time of crisis, unfortunately, EDs. Now, if you ask about the last month, it's now packed with COVID cases. But it's always been a problem, even before COVID. And it's something to be prepared for, but it's in the best interest of the child. If they need to go to ED, they really should. And just be prepared to ask good questions and advocate. And that's what I can help you with here. There's help at the end of this experience. If the inpatient is needed, I would lean towards accepting that. Some parents hesitate a lot. And unless there's a bridge program that can see you the next day, it's a higher risk to go home if inpatient stay has been recommended. So it's not an easy situation, but if you want more specifics, let me know.
All right, the next question is, can Tourette's and pandas or inflammation co-occur? My child has a genetic link to TS, but also has a dilated pupils and behavior regression.
Yes, we hear about the dilated pupils at times in some kids with OCD, Tourette's. It's non-specific as far as we know. Now, regression is very concerning, and I'm not sure what exactly it means, but it is a criteria for a neurological workup. If it's a real cognitive regression, especially with genetic testing, brain imaging, and maybe EEGs.
All right, we have a question from Jessica Salinas that says, you went over medications, but has there been studies on the use of marijuana with Tourette?
Dr. Müller-Wahl in Germany is very keen on studying this and has just published some data where not even just CBD, but THC seems to be helpful for some patients. We're eagerly awaiting more data. So there's initial data that it could be helpful. Anecdotally, I've had some patients say it's the only thing that seemed to help them. But we don't have a way to prescribing it yet. And again, we have to see if the data really holds up. And there's one particular researcher in Germany that's pursuing it very, very intently.
All right, and then we have, what is your thought on metformin as an aid to counteract the metabolic effects of medications such as Abilify?
There is good data for metformin and obesity and preventing diabetes. And if a child is at particular risks, like already obese, it would be indicated. Not in every case, but it has to be a discussion. And it is an option to use it in some high-risk cases of obesity and diabetes when you start a neuroleptic.
Then we have, if there is there a specific age or time frame when therapy methods change as a teen becomes an adult? Is there more effective treatment for older individuals?
As I had mentioned before, older individuals had actually invented CBIT. The therapists learned from the adult patients who were using those techniques. And so CBIT tends to become easier to do for older individuals, especially if the tics are significant, are big, quote unquote, tics. That would be an approach to take. On the other hand, medications can be used, but if you've had Tourette's for a long time, you've probably already tried quite a few. I would encourage another try at CBIT. And the availability of CBIT therapists is really an issue. Some therapists say they're doing CBIT and they have learned it superficially. So it's important to do some homework when choosing a CBIT therapist.
We had a few people ask, what is the relation between FND and Tourette? And it says, especially if you can tell them apart by nature of tics.
Yes, so that's such a good question, because functional neurological disorder, conversion disorder, is that condition where one has a symptom that has no organic basis. For example, you can't walk, but nothing is wrong with your muscles, your spine, and so forth. So those are the classic cases, and that's conversion or functional neurological disorder. In the pandemic, we have seen these adolescent females with unusual tics that are explosive. They've been called the TikTok Tourette's group, and they are at high risk for functional neurological symptoms as well. We've had some patients who have drifted from the unusual tics to functional neurological disorder. It's something to watch closely, because once you drift into that and you don't get treatment, it can start to set in. The treatment for functional neurological disorder is rehabilitation. It's not necessarily psychiatric. It's having the individual be reinforced and validated for regaining function. And 98% get better, 99% get better with the treatment. Tourette patients may be more susceptible to this, and this was recognized from the beginning of Tourette's by the likes of Freud. When Freud described the 5 cases of hysteria in 1895, when he wrote that little book with Breuer, which started psychoanalysis, of those 5 patients, at least a couple had Tourette's or Tourette-like symptoms, but they also had quote unquote hysteria, which was the old name for conversion disorder. But there is a interface that's not quite well understood. In some respects, Tourette's patients may be at higher risk for functional neurological disorder. We've seen that in the pandemic. But it's not something that had come out as clearly in the past.
All right, and our last question for the evening: why is flufenazine preferred over the other older neuroleptics? Has it been shown to be more effective and or less side effects? And does Johns Hopkins offer virtual visits?
Flufenazine, it is one of those things you keep in your back pocket for resistant Tourette's. Why? It's interesting because I had mentioned those older neuroleptics were mostly D2 receptor antagonists, that they block the D2 receptor of dopamine. Flufenazine is a mix. It's a D1 blocker and D2 as well. So it may be that it has a D1 effect that the others are lacking. On the other hand, the newer neuroleptics are very much a combination as well of D1 and D2, some more D2, some more D1, all kinds of things they do. So it may be that flufenazine is just a little different than the older ones in that it blocks both D1 and D2. Okay.
Okay, well, I'm going to step
think
in
I was
here.
supposed to leave a couple minutes for closing slides. Thank you for your attention. Thank you for your patience.
This was just phenomenal. If you could release screen, please, Dr. Grados.
Yes.
As I said, my phone has been going off, and what I am hearing just from what we're seeing in the chat, as well as from what I'm hearing on my phone, is just the detail you provided is information that they're not getting from their own practitioners. So we want to thank you for taking the time tonight to really drill down and be so specific, because so many of us have these questions, and being able to come together as a group and get the answer to them is just life-changing. So I want to thank you for that. I also want to thank Devin for doing such a nice job of announcing all of those medications. So thank you, Devin, for handling the chat room.
Don't
more
expect
than
I'll do it again.
There you go. So I didn't put that. Where'd we go? Hold on, I'm going to stop share real quick and make sure. We are just going to close up on, why can't I get my presentation open? Layla, could you pull open that presentation for me? For some reason, mine is not opening.
Yeah, give me a minute. I need to log in. Is it in the drive?
Yes, Devin, do you have yours open by chance?
I do not. I was
Okay.
going to say, though, for those who are trying to find the link, I have posted it a couple times. I'll do it again. There is a YouTube page that we have under TAMAC. And this is, I sent it to Phil accidentally. Sent it to everyone. We'll be posting this recorded webinar on our YouTube page.
Yes, we will also be putting it up into our private Facebook group, as well as on our page, our public page. And what we were just about to talk about here is just some of the events that are coming up. So I'll just verbally go through this. We have, as every second Thursday of the month, we run a family-friendly game night. You can find that on our event page. We're bringing everyone together. We also have two very strong support groups that are going down currently in Hampton Roads. Amber Turner, can you come on the screen real fast and talk about the two events that you have coming up?
Yeah, so my child Sam hosts a youth support group, and it really is a casual setting. It's for kids to just get together and chat and hang out. And sometimes they talk about their tics, and sometimes they talk about school or the virtual games they like to play, whatever. It's kind of laid back, and it just gives them a chance to network with each other. And then and that's always the third Sunday of each month. And then the third Tuesday of each month, which will be this next Tuesday, is the same chance for grownups, parents, adults with Tourette, to just kind of chill and chat. And it's bring your own beverage. We don't care what it is. We're all in our own homes, but and just to chill and kind of network and commiserate with each other.
Thank you, appreciate that. In addition, you have an ice skating event coming up, do you not?
Yes. So we do down here in-person events. We try to do one every month. We're doing a day on the ice on Saturday. And then in February, we've just scheduled our day in history, which is going to be exploring the outdoor areas at the Jamestown settlement.
Very key that all these events are outdoors. We're staying COVID safe, COVID with masks, separations. So it's very important we go safe on that. Anybody have that PowerPoint presentation pulled up for me?
Marla, I'm actually not seeing it in the drive.
Okay, I emailed it directly to you, Layla.
Okay.
But that's okay. We can just wing this. So we also have on a national front, we want to draw attention to National Advocacy Day virtual that's coming up. I believe that date is March 4th. You can reach that on tourette.org/events, and they're going to be able to tell you what's going on there, as well as getting involved with our Youth Ambassador program and our Rising Leader program. And then the national conference, which is coming up, I want to say the third week in May, that is scheduled for Minnesota. We're going to see if that's in person or not, or if they end up going virtual. Oh, looks like we've got it. Thank you, Devin. All right, can you advance through and see how there we go. I was off. March 2nd is the virtual advocacy day. And again, the conference is May 13th through May 15th at the Hyatt Regency in Minneapolis. So any more additional information you'd like with that? And then as you can see on February 23rd, TAA has a school psychologist guide to Tourette syndrome and co-occurring conditions, excuse me. So thank you, Devin, if you can advance that slide. Oh, this makes it really easy. A very special thank you, everyone. Dr. Grados, a very special thank you to you. I mean, so much time you put into that and making it informative and helpful to our community. I want to thank you. We hope that you will come back and see us again and again. We've already had 4 requests on my phone for you to come back. So we hope that we can schedule something with you again. We look forward to seeing everyone. We wish you all to stay safe and very healthy during these very challenging times. And, you know, I think that's just about it. So did I forget? Chime in there. TAMAC leadership. Did I forget anything?
Marla, I just wanted to just give a quick announcement for our fundraising campaign. So we're currently fundraising for our annual giving campaign. We launched it in December and we're extending it into January. I'm going to drop our landing page into the chat over here. Basically, we're just asking for donations, sharing our landing page. We use the funds to basically help provide more services and events like this. So please consider giving and we'd really appreciate it.
Thank you, Layla. Yes, everything that you see here is all on a volunteer basis. All these wonderful programs are put together, and the more funds that we have, the more literature we can get out and more awareness we can create and more events we can have for our support groups. So thank you, Layla, for that. Without further ado, I'm going to say thank you. Thank you. It is 1:38 a.m. my time, and we are signing off. So thank you, everyone. We will see you all very soon. Fabulous. Have a great day, everyone.